Okay, today I'm here to help present your lecture for today. My name is Jessica Polly. For those of you that don't know, I will be your instructor for today. We're going to cover pancreatitis, hepatitis, and cirrhosis. But before we go ahead and get started, I'm going to have you guys do a short little quiz. One of the processes is to do a pre-test, post-test. Pre-test is before you know anything, and then the post-test is to see how well I taught or how well the information was retained during this session. So I'm going to go ahead and get those handed out here. Does anybody have any questions before we get started? Okay, so obviously, as I have talked to you about these, we're going to go ahead and hand these out. I think there's only 8 or 9 questions, so don't stress about it. I apologize. I probably won't be able to give you any points, though, for this. I'll have to talk to your instructor about that once I get the answers back. Oh, I'm so sorry. I forgot to give you one. Here you go. As you finish with those, I'll go ahead and pick them up. Again, this is just for my knowledge, so that way I can assess the situation or assess the different areas that I may need to focus on for future reference as I develop my teaching skills. Thank you. Thank you. Okay, now that everybody has those done, we're going to go ahead and get started. We're going to start with pancreatitis today. This is for your complex nursing class, and then also, as you can see on the board, it's for my class for Nebraska Methodist College. The objectives for today are to compare and contrast the pathophysiology of acute and chronic pancreatitis, discuss the different diagnostic tools, and then prioritize the care for both acute and chronic pancreatitis patients. So pancreatitis is the inflammation of the pancreas. The pancreatic enzymes are released into the tissues itself instead of being released into the small intestines. There's 5,000 new cases every year, and alcohol and gallstones are generally the primary cause. The pancreas is an exocrine gland that excretes pancreatic enzymes and an endocrine gland that produces insulin. So these are things you have to keep in mind when the pancreas is affected or has signs and symptoms of infection or inflammation, of what parts of the body could be affected. There's 3 different kinds we're going to talk about. There's acute, chronic, and cancerous pancreatitis, or pancreatic disorders. Acute pancreatitis can be caused by either gallstone that obstructs the duct or alcohol that causes duodenal edema and then obstructs the pancreatic outflow. So the 2 main causes for acute pancreatitis are your gallstones that block the duct and then the alcohol. Pancreatitis is a serious, possibly life-threatening inflammatory process. There's necrotizing hemorrhagic pancreatitis, which causes lipolysis, proteolysis, necrosis of blood vessels, and inflammation. Correct. Due to that inflammation causes what causes the pancreatitis. Some of the symptoms of acute pancreatitis, it usually develops suddenly. The patients usually complain of severe epigastric pain and abdominal pain. This pain can radiate to the back. Patients may complain of nausea, vomiting, abdominal distension. Decreased bowel sounds may be a sign. Tachycardia, and then Turner's sign, which we'll talk about in just a little bit. I have a few pictures. Any questions so far? Here's a picture of acute pancreatitis. Sorry, I can't quite get my thing to switch. Wrong button. Okay, picture of acute pancreatitis. So obviously you can see the inflammation of the small bowel there. It seems really angry, doesn't it? Just seem very angry. Here's also a picture of an x-ray, or I guess it would be a CT. See the pancreas, it's still very inflamed. Some of the diagnostic tools to diagnose pancreatitis, including ERCP, where they go in and look at the gallbladder duct and the pancreas. You can do abdominal x-ray, abdominal ultrasound if a suspected gallstone is involved. They can do a CT of the abdomen, or they can do a fine needle aspiration biopsy. So all of these tools may be used depending on the severity, the signs and symptoms, because as you'll notice, some of these symptoms go along with the other ones we're going to talk about. Some of the different lab tests we're going to talk about, or that you would see for pancreatitis, include lipase, amylase, trypsin, bilirubin, creatinine. alkaline phosphatase, hematocrit, white blood cells, ESR, glucose. Why would amylase and lipase are going to be your main two when you discuss pancreatitis? Why would we even be concerned about glucose? What's going on? Correct. That pancreas is what breaks down the blood sugar, the glucose. So if our pancreas is affected, our insulin isn't going to be produced as well, which in turn, then we have high glucose levels. You're also going to be looking at your white blood cell count because of inflammation and possible infection. And when you're looking at these patients, you're going to have physical assessment. It's going to be pronounced volume depletion or fluid volume deficit. What are your signs and symptoms of fluid volume deficit? Blood pressure, low blood pressure, very good. What else? Tachycardia usually goes along with it, yes. Skin turgor. Very good, very good. You will probably have some local and systemic inflammation. Then we turn to some jaundice. Why would you have jaundice? Right, related to the gallstone if that is obstructed. Bowel sounds will be hypo, abdominal tenderness. They might have some rigidity, some guarding, a boring type pain is what they call it. They may have some pancreatic ascites. You're going to want to watch the vital signs for significant changes as they progress to shock. That pain is going to be generally up high, upper left quadrant, up middle quadrant. That's generally where they're going to complain of that pain. Again, what are our signs of shock? You're going to look for changes in vital signs. You're going to look for temperature changes. Correct. Very good. Very good. You're also going to be wondering about that inflammation. You're going to have fluid shifts, so you're going to want to monitor for that. As you're assessing these people, you're also going to want to look for those other signs and symptoms, that Turner sign. There's also a Cullen sign that we will discuss here in just a second. Those are some of your physical assessments that you will see. So here is the Cullens and the Turners. The Cullens is, these are caused by seepage of blood-stained exudates into the tissue as a result of pancreatic enzyme actions. So the Cullens is the bluish-gray periumbilical discoloration, as you can see over here. And then also the gray Turner sign is the ecchymosis on the flank area. Other things that you might consider, or things we want to discuss, is complications of acute pancreatitis. You're going to be worried about infection, hypovolemia, so again, that fluid volume deficit, hemorrhage, that pancreas as it swells becomes edematous. You would have issues with possible hemorrhage. Acute renal failure can come into play. Paralytic ileus, due to that inflammation, those fluid shifts, that hypovolemia can lead to that kidney failure. Because remember, our kidneys have to have consistent, adequate perfusion for them to maintain or adequately refuse and excrete from our body. You might have hypovolemic or septic shock type syndromes, or signs and symptoms of pleural effusion, respiratory distress, pneumonia, multi-system organ failure as you get multiple problems going together, DIC, diabetes mellitus. Why would diabetes mellitus come into play here? Yes, our pancreas, those islets of Langerhans, and the insulin is secreted in this area. So if we have inflammation and necrosis of this tissue, we're going to lose some of that insulin capability. Okay, so chronic pancreatitis, signs and symptoms and things like that for chronic are similar to your acute pancreatitis. However, chronic is where it reoccurs. Acute is an individual one sitting, whereas chronic, it happens over and over. It's a progressive destructive disease of the pancreas that has remissions and exacerbations. Some of these surgical management is your drug therapy, analgesics, enzyme replacement, insulin, diet. So your drug therapy, mainly your analgesics, they say that morphine is the big thing. Depending on which studies or which books you look at, some of them may also say Dilaudid is a big analgesic that we will use for pancreatitis. Enzyme replacement, because we're releasing those digestive enzymes into our small intestine, into our pancreas instead of our small intestine, we might have to supplement with other enzymes. And then insulin, as we've discussed, if we have necrosis of that tissue, we have necrosis of the cells that also release that insulin. So we may have to supplement with some short-acting insulin or some anti-diabetic agents. And then obviously diet. What type of diet would we want our patients to be on? Consistent carb, right? If, depending on the situation, if we're in an acute exacerbation, we would be NPO, because anytime you put anything into that stomach, you are triggering digestive enzymes to be released, you are triggering those things to happen, which then increases the pancreatitis. So you really want to be careful and make sure, if you think it's a diagnosis of pancreatitis, you keep them NPO until your diagnostic test can be performed. And then these patients can be NPO for anywhere from 3 days to 2 weeks, depending on how bad their exacerbation is. So we have to really think about these kinds of things, the insulin, the diet, and how they all are interrelated. According to pancreatitis, our pancreas does a lot of work for an organ that we don't hear much about unless it flares up. So that's something that you have to consider and think about. Here's a picture of a pancreas. You can see how it's really eaten itself away and calcified in those areas. So again, your chronic pancreatitis symptoms are going to be similar to your acute. They're going to have recurrent epigastric left upper quadrant pain. They're going to have complaints of anorexia, nausea, vomiting, weight loss, maybe some flatulence, some constipation. Steatorrhea, what is that? Yes, fatty stools. Why might we have fatty stools? Correct, because our body cannot break down, our body is releasing those enzymes in the pancreas instead of in the small intestine, and some of those enzymes are what break down those fatty tissues, those fatty foods. Some of our complications go along with malabsorption due to those different enzymes not being released and the malnutrition. You might have a pancreatic abscess due to that inflammation building up. Patients might end up developing diabetes mellitus, and then due to the long-term treatment with narcotic therapy, they will probably need, or there's a chance for narcotic addiction. So we want to make sure that we are using them only as needed, but yet at the same time provide adequate pain control for these patients. Again, that diabetes mellitus comes into play because our pancreas is necrosing due to those enzymes being released too early. That pancreas is auto-digesting itself. So when you think about autodigestion and those kinds of things happening to that pancreas, what else are you concerned about with these patients? How are we going to treat these patients? What are we going to do for these patients to help reduce their pain, to help try and prevent that pancreas from being eaten or auto-digested away because those enzymes are being released too early into that pancreas? What are some of the things that we have to consider? What are some of the interventions that a nurse might have to consider? Definitely, as we spoke about, NPO is a big thing. We want them to be NPO. Yes, and why? Right, because with these patients, the more they eat or the more they stimulate their gut, the more they stimulate those digestive enzymes to be released, the more that they then lead to increased pain, increased inflammation, increased risk for abscess and ascites to develop in the pancreas. So NPO, we're going to do opioids, generally via PCA, so the patient has control for it or of it. NG, why are we going to do an NG? Yes, because our body automatically produces some of those enzymes, so then our body has to keep digesting it and move it through, and we don't want them building up, but also we don't want to trigger that pancreas to release any more enzymes than it needs to. Why might we do some antibiotics or steroids? Antibiotics, possible infection, there's necrosis going on in there, so we may need to help fight the infection, or the infection may be of what has caused it. Steroids, what are steroids for? Inflammation, yes, helps to reduce inflammation. And then again, we talked about that ERCP earlier with acute pancreatitis. They're looking at the gallbladder and the pancreas and visualizing what's going on. We also have fluid and electrolyte replacement. So LR, normal saline. Why would we choose an isotonic fluid? Right, these patients are volume depleted. We don't want to cause any extra shifts of the fluid, but at the same time, we want to try and get that volume up. Why do we need the albumin? Albumin is a large molecule, so when we use albumin, not only is it for the protein, but it's also to help draw fluids into the vessels. So take the fluid from the extravascular spaces into the intravascular, into the vessels, in order to reduce swelling, inflammation, or edema. Pulmonary artery catheter, when I first saw this, I was like, what? It's a central line. These patients may need some type, they're going to be on lots of antibiotics, the fluids, the PCA, those kinds of things. We're probably going to want to do a central line, especially if they're going to be long-term. Then we would have to worry about possibly doing TPN or those kinds of things. So we're going to want to put a central line in pretty early in order to ensure if those steps are needed, we can go ahead and have access for that. Do we have any questions over this slide? Any concerns, anything that makes you question or? Right, isotonic. So your LR and your normal saline are both isotonic solutions. So they cause no fluid shifts. They keep them level, they keep them even. They keep no fluid goes in or out of the cells. Yes, the pulmonary artery catheter is a central line. So we could do a PICC line, we could do a central line. Either of them would work sufficiently for what we need. That would be fine, yes. The ERCP, it's kind of hard to explain. It's a scope that goes in and looks at the gallbladder and the pancreas, checking for gallstones, checking for inflammation, those kinds of things. It's a diagnostic test to figure out what's going on, to help try and determine what it was caused by. Yes. So some of our nursing diagnoses include acute pain, obviously for the acute situations, and then also chronic, if it becomes a chronic problem. Ineffective breathing pattern related to decreased lung expansion or pain, and fluid volume deficit related to hemorrhage, and increased vascular permeability, and then possibly altered nutrition. Do any of these surprise you, or do they all seem to fit into your thought process of what you're thinking for pancreatitis? Well, I've broken some of these down with some of the interventions and the considerations that you need to think about on these next couple slides. So, ineffective breathing pattern related to decreased lung expansion and pain. So you're going to assess for hypoxemia due to the hypovolemia, the pain, and the narcotics. You're also going to watch for an overload of toxins due to the breakdown of that pancreas, due to the necrosis or the autodigestion of that pancreas. So some of your indications for this hypoxemia that you're looking for are your decreased O2 stats, less than 92, and you may only have abnormal ABGs. You're going to monitor for increased or decreased respiratory rate. When would we see increase? Yes, generally if they're complaining of pain, you will see increase. Decrease? Why would we see decrease? Very good, because narcotics, they're probably going to be on a lot of narcotics. Pancreatitis is very, very painful. You're also going to watch for labored breathing or shortness of breath. You're going to assess for abnormal lung sounds. Restlessness, anxiety, or decreased LOCs show poor oxygenation. All things that you want to monitor for. So when you're thinking imbalanced nutrition, less than body requirements, you're thinking interventions. You're going to have them NPO early. You want them to have that NG if those antiemetics that don't work. If they're still over salivating, getting extra, feeling like they're going to vomit all the time. What kind of antiemetics might we use? Zofran, yes, very good. What was that one? Oh, Phenergan. Phenergan is an older style one that we don't use as much anymore unless the other ones fail. Anybody know the other one that we might use? Reglan, correct. So TPN, as I said, we may need that central line for the TPN for those patients that are NPO for a long period of time. You're also going to do small, frequent, moderate to high carbohydrate, high protein, and low fat diet when they are able to resume oral intake. And then we want to avoid those foods that cause GI stimulation, such as fatty foods, hot and spicy foods. Those kinds of foods would be the ones. You also want to think about patients don't like to be NPO, but you have to make sure you educate them why they need to stay NPO. NPO, they think you're not going to feed me. Our bodies can go for a little while without food. And then if we do have to go long term, we can always start the TPN and things. So let's go over a few NCLEX questions. What's the priority nursing diagnosis for a patient with acute pancreatitis? Risk for deficient fluid volume related to abnormal and normal routines, nausea related to pancreatic disease, risk for infection related to necrotic pancreatic tissue, or acute pain related to biologic acute pain related to biologic injury. Why is my slide not going? Oh, there we go. So it's going to be D. Sorry about that. So a pancreatic abscess is the most serious complications. It's always fatal if not treated. Recurrence is common. Signs and symptoms of this are going to be a high fever, so you're going to want blood cultures. They may do drainage via a percutaneous, so a drain placed in there, or a laparoscopic procedure. And then obviously, and as this says, antibiotic therapy alone is not effective. So you can't just do antibiotics, you're going to have to do some form of surgical treatment also. So the different surgical management would be your perioperative care, NG, as we talked about, TPN. The operation may include a Whipple. I did do a video on the next slide. I'm not going to play it at this exact moment, but it is on there for your use. You have the post-operative care, so you're going to observe for complications. You're going to monitor GI drainage, monitor positioning. What's the best position for somebody with an NG? Right. It's going to be semi-Fowlers or high Fowlers. We don't want these people laying down if they're getting all built up with fluid. That could just cause more complications. You're also going to want to do fluid and electrolyte assessment and management, and then glucose monitoring. Again, why are we doing the glucose monitoring? Correct, because of the fact of their pancreas not able. So this is a picture of a Whipple procedure. As you can see, they have taken off the head of the pancreas and gotten rid of the gallbladder and also gotten rid of some of the small intestine. They have to reanastomose the bile duct, and then the small intestine and the stomach have to be reattached to the pancreas. This Whipple procedure is a big procedure, and complications can arise very easily. So you want to make sure you're monitoring. One of the main things you're going to monitor is that NG. You don't want a lot of extra fluid built up from that NG. And we'll talk about that here more in just a second. Any questions over a Whipple procedure? So what are we going to do to teach our patients? If this is what we're going to do, what are we going to do to teach our patients? What are we concerned about? What are some of the things that causes this, or some of the things that are prevented? Correct. Alcohol. You want to be careful with alcohol consumption, especially if you're already diagnosed pancreatitis. We need to tell them that smoking and stress can stimulate the pancreas. So if they're already in an acute situation with pancreatitis, don't smoke and relax. Medication regimen. It's very important to maintain your medication regimen. Low-fat diet, because our body has troubles breaking down that fat. Report signs and symptoms of infection, which are good. Temperature, yes, very good. Increased respiration. And then you may do a dietitian referral if necessary to help educate them about their different diets and those things. You also may remember that medication regimen, we talked about those pancreatic enzymes. If our patients aren't producing the pancreatic enzymes into the small intestine, we may have to do some oral pancreatic enzymes. So let's move on to some in-text questions. A 55-year-old woman admitted with acute pancreatitis says, I don't understand how I got this. I thought alcoholics got pancreatitis. I've never drank. Which of the following responses is most important? Was there a time in your life that you did drink heavily? It also is prevalent in smokers. Do you smoke? Gallstones are a risk factor. We'll evaluate you for them. Intravenous drug use is a risk factor. Do you use drugs? 1, 2, 3, 4. Yeah, it is 3. The rationale. In women, the most common contributing factor to development of pancreatitis is gallstones. So here's another question. Oh, I'm sorry. Yeah, I'll let you read them. So, who says 1, 2, 3, 4? It is 4. Again, as I said, we talk about this in a minute. Maintaining patency of that NG tube is important to prevent the pressure on the anastomosis created in that Whipple procedure. You don't want it to build up and break open those sutures and the work that has been done by the surgeon. Does anybody have any more questions or anything like that? Is there anything else I can do for you? So that is the end of pancreatitis. We will go ahead and finish with hepatitis and cirrhosis here in just a little bit.